Good afternoon, all of you. Hi, Mahesh. I hope I'm audible and visible. So just confirm the same in the chat box very quickly. And I believe that all of your preparations for this FMG exam is going on in good flow. Right? So thank you so much for confirming, Mahesh, John, all of you. So the idea here is, as we have started the FMG marathon yesterday, so here today we will be discussing about dermatology, and in a few hours, 𝐒𝐿𝐿𝐿𝐿 ma'am will be discussing about gynecology and obstetrics as well. So thank you so much, Ramesh, Musaddiq, Siddhant, Walaikum Salam. Thank you so much. So let's start our day now. So the idea here is we have a workbook and almost around 40 to 45 pages. And what we will try to do is we'll have a quick revision about the most important topics in dermatology that you must be knowing for your exam, right? So since you have already prepared, let's see how far you're able to recollect whatever we have learned till now. And I would suggest that all of you please try to make it an interactive crowd today, so that once you answer my questions in the chat box, that will give me more energy, isn't it? So now let's start without wasting any more time. So yes, I hope all of you have entered into the Sankalp Telegram group where all the faculties are together with you. And this is a schedule. So as you know that today it will be dermatology and OBG gynecology. So now let's start with dermatology now. Okay, thank you. So now let's start. So now let's starting with the first image. Okay, we begin with the image itself. So what is the first image that you see here? So this is one of the most important topics that we always study in dermatology, right? So this is actually representing a cell which is present in the stratum spinosum. And if you do an investigation which is called as a electron microscopy, you will be able to see this image. What is that? Yes, Harsh, Pooja, Mahesh, all of you are saying the right answer. So this is an image of Langerhans cells. It is an image of Langerhans cells. And please remember, how do you compare a Langerhans cell to? So Sagufta is saying that we call it as Birbeck granules. Does all of you agree with him? So this is also called as Birbeck granules. Very good. This is also called as Birbeck granules, or it is compared to a tennis racket cells, or it is compared to a tennis racket cells. So that is all about the first image. Okay, the first image is about Langerhans cells, and you can see that the shape of the cell is something like this, because of which we compare it to a tennis racket. It's also called as a Birbeck granules, and the layer in which you find these kind of cells, it's called as a stratum spinosum. It's called as a stratum spinosum, and this is how you can see a Langerhans cells. And don't make any silly mistakes on the day of your exam, because on the day of the exam, if they ask you what happens in a normal microscopy of Langerhans cells, can anybody answer this question in the chat box? Because just now I told you that a Langerhans cells under an electron microscopy looks like a tennis racket cells, also called as a Birbeck granule. Now what about a normal microscopy of a Langerhans cell? Come, just make a guess. What do you see in a normal microscopy? And this is the clue for you. Yes. So here you can find it as dendritic cells. So why is this a clue? This is a clue because there is a finger-like projection, or you find it as a dendritic cells. So very good, Harsh, Mahesh, all of you, Arjun, Pooja, all of you are answering. So all these are the right answer. So don't make a mistake. Please read the MCQ very carefully. अगर electron microscopy है, the answer should be Birbeck granule. अगर normal microscopy है, the answer should be dendritic cells. So now let's see another investigation. अब ये कौन सा investigation है? The first image that you see here, what is this? This is called as, yeah, anyone? Because in the second image, you can see that once you light this investigation, there is some bluish discoloration that can be seen in the scalp area. So yes, once again, I'm getting the right answer in the chat box. Excellent. So this is called as a Woods lamp examination. And please remember, in Woods lamp, remember that the wavelength of a Woods lamp is 365 nanometer. The wavelength is 365 nanometer. And what is most important is this table. So all of you have to memorize this table, because in some diseases, it may show you a certain color of fluorescence, out of which when you see the scalp, if you see a green color fluorescence, this can be seen in Tinea capitis. And in Pityriasis versicolor, which is called as a fungal infection, here you can find a pale yellow or an apple green. In one of the FMG exams, they asked you what is the fluorescence that can be seen in erythrasma. So remember, it's going to be a coral red fluorescence. Some diseases like vitiligo will give you white, and porphyria cutaneous tarda, especially in the urine, will give you a red or a pink color fluorescence. So this is very important that you remember the findings of the Woods lamp. So this table is again very important for all of you. So moving to the next one. So this is another investigation. So what is this investigation? Because in this image, you can see that. So there is small scraping that is done to the skin, and the contents of the scraping is collected in a glass slide. What is this test? This test, yeah, very good. All of you are answering it. This is called as the 𝐒𝐄𝐝 test. So in this 𝐒𝐄𝐝 test, even before anybody looks into the table, can you just focus on this 𝐒𝐄𝐝 finding? Because for me, in this 𝐒𝐄𝐝 finding, I can see some balls here, and I can also see some long strands of fungus as well. Any idea what is the disease in which you get this kind of a 𝐒𝐄𝐝 finding? Yes, don't recall the message. You are absolutely right. That is a spaghetti and meatball appearance, right? So in which disease do you get a spaghetti and meatball appearance? So this finding is seen in this disease. That is Pityriasis versicolor, where you can find the fungal hyphae and spores together as compared to the banana and grapes or spaghetti and meatballs appearance. Excellent. So happy baseball. Tell me, is it Malassezia furfur or Malassezia globosa? What is more common in Pityriasis versicolor? So please remember, Malassezia globosa is more common than Malassezia furfur. Okay. So since we are talking about potassium hydroxide test or 𝐒𝐄𝐝 test, remember two more conditions. Like in dermatophytosis, you will always find a fungal hyphae. Whereas in candidiasis, you can also always find a pseudo-hyphal elements. Okay, pseudo-hyphal filaments can be seen. So hyphae, matlab, think about dermatophytosis. Pseudo-hyphae, think about candidiasis. And also spaghetti and meatball appearance. Spaghetti and meatball appearance means you always think about Pityriasis versicolor. So now let's go to the next image. Now what is this investigation that is being done in this image? Anyone? So this investigation here, where you can see that, I'll just zoom this image for you. So in this image, you can see that there is a vesicle near the lips, isn't it? So yes, this investigation is called as a Tzanck smear. So when do we do this investigation called as a Tzanck smear? Whenever you have a vesiculobullous diseases. So when you have a patient who is having a vesiculobullous disease, we do this investigation called as a Tzanck smear. So what is important for you is the Tzanck smear findings. So please remember, there are two very important Tzanck smear findings. The first one is called as a Tzanck cell or a 𝐒𝐿𝐻𝐿 cells. Now, this is the finding that I mentioned here for this image, and there is another finding that we can see here as well. So please remember what happens is in a Tzanck smear, in pemphigus group of diseases, there is a defect of what is the defect in a pemphigus group of disease? There can be a defect of desmosomes. So all of you remember that the function of a desmosome is that it acts like a gum or a glue, because if imagine this is a keratinocyte, this is a keratinocyte, they are both glued together because of this thing called as a desmosome. So whenever there is a desmosomal defect, what happens? The cells will get separated from each other because the gum or the glue is defective. And whenever the cells are getting detached from each other, they become rounded cells with a large nucleus like this. And these are called as acantholytic cells, which can be seen in pemphigus group of diseases. I hope all of you remember this, right? Or what happens in some infections where you find some vesicles over the trunk? Infections like herpes simplex virus, that is HSV, or varicella or herpes zoster. Here you can find multinucleated giant cells along with Tzanck cells. Okay, you can find multinucleated giant cells. So this is an image of multinucleated giant cells. So it is an image of multinucleated giant cells. So what all of you will remember is, agar koi infection hai, then always go for multinucleated giant cells. If it is going to be a disease like pemphigus group of disease, जैसे pemphigus vulgaris, pemphigus foliaceus, then your answer should be Tzanck cell or acantholytic cells. Now, what about this investigation? So what is happening here? So here what you can see is the examiner is going to press the skin with a glass slide. Can anybody tell me what is the name of this investigation which is done in dermatology? So how many of you agree with no problem, Jansi? So what is this? Yeah. So this is called as Diascopy. So this is called as Diascopy. So Diascopy is a very simple investigation that is called as what you do here is you're going to just press the skin with a glass slide. Now what is happening here is when we press the skin, that area of the skin is blanching. So if that area of the skin blanches, what does it mean? That is always seen in erythema. Okay, so whenever you have a erythematous skin, when you just press with the glass slide, it is going to blanch, and that is called as erythema. Whereas in the second image, I'll just zoom the second image for you. When we are pressing over the skin with a glass slide, is it blanching? Is it blanching? No. So there is no change that can be seen. So this one is called as petechiae, purpura or ecchymosis. So whenever there is an extravasation of blood, so it can be called as either petechiae, purpura or ecchymosis based on the size. Okay, based on the size of the lesion. And these lesions are not going to blanch. Now always remember, we are not doing, yes, Ambali. Okay, but unfortunately I can't teach in Malayalam because we have to cater to a bigger audience, right? So now let's see. So now what do we do is that in Diascopy, so in Diascopy, what is the most important thing is it is not only done to differentiate between an erythema and a petechiae. It can also be done for many other diseases. Please remember this very, very important thing. What is the Diascopy finding in lupus vulgaris? And what is the answer? So what is the Diascopy finding in lupus vulgaris? How many of you remember what exactly is a lupus vulgaris? Lupus vulgaris means it is a anyone? The chat box. What exactly is the lupus vulgaris? Lupus vulgaris means it is cutaneous tuberculosis, isn't it? This is going to be cutaneous tuberculosis. So in cutaneous tuberculosis, you can see something called as apple jelly nodules. Whereas in sarcoidosis, we can see sabudan jesa appearance, that is called as sago grain appearance. And one more diseases that you will learn is nevus depigmentosus and nevus anemicus, because this, by the name itself, depigmentosus, it's a pigmentary defect, hence it will not blanch. Whereas nevus anemicus, this is a capillary defect, hence again you can find blanching. Hence you can again find blanching. So what is important for you is, if at all they ask you about some investigations, just a diascopy. So this table is more important for you. Please remember all the diascopy findings in this table. So now moving to the next one. So now we are going to talk about some lines in the skin. So what are these lines in the skin? Now seeing this first lines, can anybody tell me what is this lines? Make a guess. What is the name of these lines? What I can see is in the anterior chest wall and all, there is a pattern something like this. You'll get the PDF in the Telegram group. Okay, MN Gaming. Okay. Yes, very good. So yes, the correct answer, I get maximum correct answers in the chat box. This is called as Blaschko lines. So these Blaschko lines, they are usually invisible lines, especially in the anterior chest wall and all. You can see that there is a V-shaped pattern, right? There is a V-shaped pattern. That is why we can call it as a Blaschko lines. Please remember 3 diseases where you can find Blaschko lines. You can remember them as HIE. So you can remember these lines as HIE. So what is HIE? H stands for hypomelanosis of ito. I stands for incontinentia pigmenti. E stands for epidermal nevus. So these are the 3 conditions where we can see Blaschko lines over the skin, because otherwise they are invisible cell development lines. Otherwise they are going to be invisible cell development lines. Okay, so whenever you get a question about any skin line, there will be another which is equally important. I'll just zoom this image for you. You can see multiple parallel lines over the skin. So any idea what are these lines in the skin called as? What are these lines in the skin called as? Again, I'm getting the right answer from Mahesh, son of Krishna. So what is this? So this is called as, Sagupta is also answering, Sneha is also getting it right. So this is called as Langer's lines. Now what is the significance of Langer's lines? What is the significance of Langer's lines? Yeah, Dr. Shaikh is also answering, Arjun is also answering right. So this is important surgical lines, right? So these are important surgical lines, because whenever you want to give a incision over the skin, we always give a incision. Yes. Yeah, surgical incisions are made through it. That is right. But how is a surgical incision made? Like there are 2 options. You can give an incision like this, that is parallel to the Langer's line, or you can give an incision like this, that is perpendicular to the Langer's line. What should be the answer? So, yes, the answer here should not be the second one. The incision is always given parallel to the Langer's lines. The incision should be given parallel to the Langer's lines. So please remember, it should be given parallel. Why parallel? Because of a better wound healing and a less chances of scarring. Very good, Ramesh. So all of you are, whoever is answering it right, excellent, very good. So that is the most important point that you need to remember regarding Langer's lines. Now, we know another very important topic in dermatology is going to be regarding hair disorders. So what happens when it comes to a hair disorder is that there are different types of hair loss that all of you would be knowing, right? So in these different types of hair loss, there are two terms that is important. One is non-cicatricial alopecia. The other one is cicatricial alopecia. Now, what do you mean by non-cicatricial alopecia? Anybody who can give me a much common name for non-cicatricial alopecia in the chat box? What is that? Much more common name for a non-cicatricial alopecia. This is also called as non-scarring alopecia. It is also called as a non-scarring alopecia. Okay? Cicatricial means scarring alopecia. So how can you easily remember? You can easily remember that anything that starts with A or T. Okay, so here we have a mnemonic which is like ATA. Okay, or remember that anything that starts with A or T is going to have a non-scarring alopecia. The examples are androgenic alopecia, alopecia areata, trichotillomania, telogen effluvium, and nagen effluvium. So all these are non-scarring alopecia. Whereas the examples of scarring alopecia are these, like the discoid lupus, Lichen planus, it's also called as Lichen planopilaris, Kirion, which is a fungal infection, pseudopelade of Brock, and folliculitis decalvans. All these are examples of non-scarring alopecia, of scarring alopecia. It says examples of scarring alopecia. So now let's see some of the hair disorders. Now first I'll zoom in this image to all of you. अभी पहले देख लो कि all these are three images. Can you tell me one single diagnosis? Varshit, very good. In morphia also you will get a scarring alopecia. Excellent. A linear type of a scarring alopecia, right? So Varshit, I can add morphia here where you can get a linear type. Okay? So Abhi, let's see this one. I'm getting some of the answers in the chat box now. Excellent. Because what your eyes should be able to see on the day of the exam is that if you get an image like this, there is an area of alopecia here. There is another circumscribed area of alopecia here, which means there is a patchy alopecia. Patchy alopecia, and this patchy alopecia is called as alopecia areata. It is called as alopecia areata. So in alopecia areata, remember, it is an autoimmune disease. It is an autoimmune disease. Now, what are the second and third images? Because I've given only those very important images in this workbook. So what is this image? So this image is actually an image of trichoscopy, isn't it? Where you can see it under a microscope. So in a trichoscopy, what you can find is the hair becomes something like this. What is that? Yes, I'm getting the answer here. This is called as a exclamation mark sign. Exclamation mark sign, which can be seen in a trichoscopy. Now, what about this last image? So in this last image, if you want, if I just zoom in, again, you can see that there is a patchy hair loss here. There is a much bigger patchy hair loss here. And the patient has lost all the black hair. And there is a retention of white hair. So what is that? So this retention of white hair, so this one is called as, very good Harsh, Ramesh is also answering, this is called as a turning gray phenomenon. So this is called as a turning gray phenomenon. And where do you find all these kind of findings? It can be seen in alopecia areata. So in the meanwhile, Mahesh and uh, Dushmesh Bhatt, both of you were telling about some kind of a nail pitting. So if you are able to see something very regular like this, some regular and shallow nail pitting, regular and shallow nail pitting, this is also seen in alopecia areata. So this is also seen in alopecia areata. So then let me ask you, where exactly or in which disease did you learn that there can be a nail pitting like this, which is like quite deep, and this is not regular. It is irregular and deep. So where do you find them? Irregular and deep nail pitting. So this can be seen in anybody. Very good. Harsh, Arjun, Ambili, Pooja, Musaddiq, all of you are answering it right. This can be seen in psoriasis. This can be seen in psoriasis. Now, since we have started talking about some of the nail, so let's talk about more nail disorders now. So what about all these nail findings? If I just zoom these images for you, just in one go, if you just see that there is a whitish discoloration like this over the nails, can you give me a spot diagnosis, like where do you find them? So Pooja says that this is true leukonychia. I completely agree with Pooja. No, this is not half and half nail. Something else. Yes, this is called as Mees lines. So Mees lines is an example of a true leukonychia, and this can be seen in poisoning. Can anybody tell me in which poisoning can we see those? Yes, it can be seen in arsenic poisoning. How about one more poisoning? Arsenic poisoning, as well as, yeah, thallium poisoning, as well as thallium poisoning. Now, how about the next one? The next image is also an example of leukonychia. Uh, why do I say this is leukonychia? क्योंकि यहाँ पे भी you can see that there is a whitish discoloration over the nails. So this one is an example of a pseudo leukonychia. So this is an example of pseudo leukonychia. Why is this pseudo? Yes, very good. I'm getting a more specific answer in the chat box. Amazing level of preparations. Okay. So this is called as SWO, that is superficial white onychomycosis. So what happens here is, I call this as pseudo because it is not the nail which turns white in color. This is because of a fungal overgrowth. And this fungal overgrowth is called as superficial white onychomycosis. Yes, Arjun, pseudo is fungal. Correct. So now let's go to the next one. So then the next one, what I can see is, I'll just zoom this image for you. I can see that there are multiple parallel white lines like this. So when you see these kind of parallel white lines, what should be your diagnosis? Yes, I'm getting the answer as this is a Muir-Keys lines. Very good. So this is called as Muir-Keys lines. How many of you remember two diseases or two conditions where you can find Muir-Keys lines? Excellent. You can see this in chemotherapy and hypoalbuminemia. So please remember, if you see that there are multiple parallel white lines which you can see on the day of your exam, this can be seen in two conditions. It can be either a chemotherapy or a hypoalbuminemia. So sometime earlier, one of you were telling about half and half nails. Now this is what you call it as a half and half nails. So focus on this image very carefully. You can see that half of the nails have turned white in color. अभी कौन सा half has turned white in color? Proximal half has turned white या फिर distal half? Yes. So here, this one should be proximal half has turned white in color. So we call it as half and half nails. So these kind of nails is also called as Lindsay nails. It is also called as Lindsay nails. Now, in which disease do you find this Lindsay nails? We find them in chronic renal failure. So we see them in a chronic renal failure. Okay? Now see the last image. So in the last image, what do you find here? Almost the entire nail, I'll just zoom this for you. Almost the entire nail has turned white in color, right? So whenever you see something like this, what is it called? Excellent, Pooja. Anyone else who knows the right answer here? Yes, Arjun, Dr. Mondal, Harsh, all of you are answering. Excellent. So this is called as terry nails. So in terry nails, in which kind of a patient are you expecting to see a terry's nails? Which kind of a patient? Is it anemia or something else? Yeah, very good. This is more likely to be seen in hepatic failure. So this is more likely to be seen in a hepatic failure. Excellent. So few more nails because this is one high yield topic, right? So we don't want to lose out on anything. So in this image, what I can see is a patient is coming to you. He's having a nail finding, and in the lateral nailed fold in this patient, so the lateral nail fold has become inflamed. Some yellow discoloration can be seen. What is this? Very good. So all of you are giving the right answer. So this is called as paronychia. So whenever you find a patient is having paronychia, what would be your treatment? Because this yellow discoloration that you see, it should be a pus, right? So you are going to give a small incision over the nails, over the lateral nail fold, and you're going to drain off the pus, right? So the treatment here should be incision and drainage. Excellent. And what is the usual causative of paronychia? Yes, the causative here is going to be Staphylococcus aureus. It is going to be Staphylococcus aureus. How about the next image? This image. So in this image, what you can see that there is some depression over the nails and the entire shape of the nails have now changed. Now what is this? Yes, this is called as a spoon-shaped nails. Spoon-shaped nails. And does the spoon-shaped nails have a specific name? Yes, this is called as 𝐒𝐿𝐿. Amazing. Okay, this is called as 𝐒𝐿𝐿, and 𝐒𝐿𝐿 is most commonly associated with iron deficiency anemia. It is associated with iron deficiency anemia. Clear? So, chalo. After talking about all these nail findings, now let's see some more images. Now, just zoom this image for you. I'm seeing that in both the cases, the axilla of the patient is being shown. So can you just give me a common finding here? Like this can be a disease of dash glands, acne inversa, Fordyce lesion. Yeah, PW is seen, I know. So yeah, even though the image is not very clear, I would say that there are some connecting bridges here. So this is a disease which is called as hidradenitis suppurativa. So this is a disease which is called as hidradenitis suppurativa. So Mahesh, very good. So in both the cases, this is going to be a disease of apocrine sweat glands. So in the first image, you can see that the patient would be developing multiple nodular lesions over the axilla, and there would be some interconnecting bridges. So there would be some interconnecting bridges. Whereas earlier some of you were telling about Fordyce spots. Is it really Fordyce spots or are you making some silly mistakes here? So whenever there is a apocrine sweat glands disease and the patient develops multiple small papules like this over the axilla, so this is called as Fox-Fordyce disease. So this is called as Fox-Fordyce disease. So even Fox-Fordyce disease is also a disease of apocrine sweat glands. It is also a disease of apocrine sweat glands. So we have just revised two of the apocrine sweat gland diseases. एक हो गया hidradenitis suppurativa और दूसरा है Fox-Fordyce disease. दोनों diseases are going to be apocrine sweat gland diseases, where in the first one you can find the patient is having some interconnecting bridges, and the second one the patient would be having multiple small papular lesions over the axilla. So now moving to another very important disease, a commonly asked topic, right? That is going to be acne vulgaris. Now in acne vulgaris, first let's label the images. ये जो first image है, how can we label this first image? Yeah, it's vulgaris. Okay, it's not okay. Now, what is the first image? ये जो image है, is there any name that you would like to give? Yeah, this is a open comedone. And whenever a comedone is open, what is the color? The color is going to be black. Very good. That is why we also call it as a black heads, isn't it? We also call it as a black heads. So please remember, this is the open comedone. The second image should be a closed comedone. The second image is a closed comedones. That is why we can see a lot of whitish lesions, isn't it? Whitish lesion. इसीलिए we call it as white heads. We call it as white heads. And how about this third one? This third image, I have zoomed it maximum for you because I can see both papules as well as some lesions like this. Small pustules can also be seen. So this would be, yeah, papulopustular. Papulopustular acne. And what if you see this kind of a very large lesion on the day of your exam? How are you going to name this kind of an acne? Yes. So this one is called as nodulocystic acne. But for nodulocystic acne, I would love to hear one more name from all of you, because we have no idea how are they going to ask a question on your day of the exam. So for nodulocystic acne, I can see that Harsh, Sirisha, all of you have answered, isn't it? Conglopata. So this is called as nodulocystic acne. So can all of you just confirm if my audio and video is all fine? Because some of you were saying that it is stuck. So if you just reply me if it is okay or not. It's stuck. So just a minute. Can you please confirm if it is working fine now? I can see that my internet is all working. The Jumble Studio, it depends upon what kind of practice you do, because if you are going into cosmetology, yes, the earnings are good, and it completely depends upon the kind of practice. Okay, so yes, So regarding acne vulgaris, so just coming back, I hope that the things are fine now. I hope the audio is all fine. It's lagging. Okay, just a minute. Give me a second. Mercy, you can find the annotated PDF in the Telegram group, in the FMGE Sankalp Telegram group today. Okay? And can all of you just confirm? If you all confirm, just imagine that you got a short break. Voice is okay, video is lagging. Okay. I'm just sorting it out. Just wait. So now let us talk about some of the treatment of acne vulgaris. Okay? So in acne vulgaris, can you tell me what would be the treatment in all the types of acne except for severe acne? So what would be the treatment except for severe acne? Yes, very good. So Harsh is answering it right. So here it should be topical retinoids. So here it should be topical retinoids. Now, what about a severe acne then? So when a patient is having a severe type of an acne, what should be the treatment? So यहाँ पे all types is topical retinoids, but in the case of severe acne, it should be oral retinoids. Oral retinoids. And how many of you remember? Never steroids. It should be retinoids. ठीक है? क्योंकि when it comes to face, if you are going to apply any steroid ointments or creams, that can actually flare up acne because of a side effect as well. So always go for retinoids as your answer. And when it comes to a severe type of acne, your answer should be oral retinoids. But what is the problem with oral retinoids, especially isotretinoin? So when it comes to isotretinoin, the problem here is that the patient will have a lot of side effects. Now, can we quickly write down what are the side effects of retinoids? What are the side effects of retinoids? Yes, dryness. I agree. Dryness is one. That is the most common. Harsh is saying teratogenicity. I agree. Teratogenicity is another one. Night blindness, excellent. Night blindness. Feels so good to just see the chat box and just write down all the answers. It shows that your preparations were going very well and fine. Depression, excellent. Depression. Anything else? I think we are missing on one. Yes, and finally Shanid has given that answer as well. That is going to be dyslipidemia. This is going to be dyslipidemia. So all these are going to be the various side effects of oral retinoids like isotretinoin. Now, when it comes to isotretinoin, what is the teratogenicity period? Let us also write down what is the teratogenicity period. Is it going to be very long, like 3 years, or is it going to be a short teratogenicity? So here the teratogenicity is going to be 1 month. Okay, it is going to be 1 month. Okay, good. So now let's go to the next topic. Now, after discussing about acne vulgaris, we are going to talk about another one that is going to be called as contact dermatitis. See, in contact dermatitis, all of you, most likely what are they going to ask you is they may give you an image or they may give you a clinical history. They will try to ask you about the diagnosis. Remember, there are two types of contact dermatitis. One is irritant contact dermatitis. The other one is allergic contact dermatitis. Easy to remember, whenever a contact dermatitis happens due to some chemicals, let's say because of detergents, dishwash or organic solvents, it is going to be irritant, okay, irritant contact dermatitis. Whereas everything else, whatever you can think about, is going to be allergic contact dermatitis. Clear? Now just see this image. Now see this first image. Patient is saying that there is a lot of dryness, irritation over the skin, and there is some scaling over the skin. And in this case, are you going to suspect? Are you going to suspect a allergic contact dermatitis or irritant contact dermatitis? Very good. So here you are going to suspect a irritant contact dermatitis, right? So this is ICD. And what is it going to be because of? This is going to be because of detergents, because the most common cause is detergents. That is why we call this kind of an eczema as a housewife's eczema. Whereas if you see an image like this, and in this image it is very clear that the patient has got a lesion just at the site of contact. And what could have been the culprit here? What can cause this kind of a contact dermatitis? Yeah, this is going to be allergic contact dermatitis. This is going to be allergic contact dermatitis. Yeah, because of slippers, rubber slippers especially, because of paraphenylene diamine. Very good. Paraphenylene diamine. Now, in the cases of contact dermatitis, do all of you remember what is the most common cause of allergic contact dermatitis? Because allergic contact dermatitis is not commonly caused due to cement, artificial jewelry, bindi, all these things. So what is the most common cause? The most common cause of allergic contact dermatitis is Parthenium hysterophorus. It is called as Parthenium hysterophorus. And Parthenium hysterophorus, this is actually a, what is it? Yeah, it is a plant, isn't it? So this is also the cause, it is the most common cause of phytodermatitis as well. So this is also the most common cause of a phytodermatitis as well. Clear? And this one, another image for you regarding contact dermatitis. Now, what has happened to the forehead of this patient? In the forehead of this patient, you can see that the patient is having some, yeah, allergic rash over the forehead, right? So this is due to bindi dermatitis. Bindi dermatitis. And this bindi dermatitis, what is it caused due to? This is it ICD or ACD? This is again going to be ACD, and the culprit is PTBP, isn't it? Para tertiary butyl phenol. So this is due to para tertiary butyl phenol. Clear? Excellent. Now, after talking about allergic contact dermatitis, let us talk about another very important topic in dermatology. And what is this? So anybody who can tell me the spot diagnosis seeing all these things? Anyone? Yeah, very good. The first one, this should be guttate psoriasis. Excellent, Mahesh. So this is guttate psoriasis. So this guttate psoriasis, what is the history in a guttate psoriasis? Yeah, what is the history? Is there any history of a preceding infection in gutted psoriasis? Yeah, gutted psoriasis will have a history of streptococcal sore throat, isn't it? They will have a history of a streptococcal sore throat. Excellent, Pooja. So now what about the second type of psoriasis that you can see here? In this second type of psoriasis, this is the most common type. Okay, this is the most common type. This is called as the chronic plaque psoriasis. This chronic plaque psoriasis is also called as psoriasis vulgaris. Psoriasis vulgaris. So what is the most common presentation in a chronic stable type of a psoriasis? Kyunki, where do you find the lesion? Do you find them in the flexures or in the extensors? कहाँ पे दिखते हैं? Psoriasis vulgaris. Psoriasis vulgaris. Always remember, this is the typical presentation. The typical presentation is the patient will have what is the color of the plaque lesion? Yeah, all of you are answering it as extensor. Amazing, very good. You are right. And what about the color of the plaque? Yes, the plaque should be erythematous plaque with what is the type of scaling? Yeah, silvery white scaling. Silvery white scaling. And this is seen over the extensor surfaces. So it is seen over the extensor surface, isn't it? So that is how you can see psoriasis. You all should remember this one, okay? Because psoriasis, 100% you're going to get a question from this topic. And whenever you see a erythematous plaque and a silvery white scaling over extensor surface, think about psoriasis vulgaris. And what are these type of psoriasis called as? If you find these kind of psoriatic lesions only over the palms and soles, so in this case, you will call this as palmoplantar psoriasis. And how about the last one? Anybody? Because usually we find psoriasis over the extensor surface. But in this image, you can see that there is a psoriatic plaque over the axilla, matlab flexural surfaces. So this one we call it as, very good, this can be called as inverse or flexural psoriasis. So this can be so called as inverse or flexural psoriasis. Now psoriasis, when you learned about psoriasis, all of you learned that psoriasis is not only plaque psoriasis, क्योंकि pustular psoriasis भी हो सकता है, right? So अगर pustular psoriasis is localized to the palms and soles, we call it as localized pustular psoriasis. And what is the second type of pustular psoriasis? The second type of pustular psoriasis is something which looks like this, which is going to be generalized, है ना? क्योंकि you can see the entire trunk has become red in color. Over the trunk, you can see a lot of pustules as well. So this is called as generalized pustular psoriasis. Now, my question is, who remembers another name or a synonym for generalized pustular psoriasis? For generalized pustular psoriasis, who remembers one more name? Impetigo herpetiformis. I think we need to wait for that, not impetigo herpetiformis. Anything else? Yeah, I got the answer from Pooja. Yes, Chetan, we are covering everything that is important here. Okay? So the correct answer here is von Zumbush reaction. Okay? Generalized pustular psoriasis is also called as von Zumbush reaction. In that case, why did someone mention about impetigo herpetiformis in the chat box? Impetigo herpetiformis. was mentioned in the chat box just now. So Rishabh, Harsh, Sneha, all of you are right. Now, what about impetigo herpetiformis? Dr. Mondal told about impetigo herpetiformis. This is generalized pustular psoriasis in pregnancy. That is about generalized pustular psoriasis in pregnancy, isn't it? That is called as impetigo herpetiformis. It is a misnomer. Very good. Now, what if you had a patient of psoriasis? Tomorrow you're getting an MCQ like this. There is a patient of psoriasis. Now the patient has come to you with massive scaling over the skin. And the skin has turned red in color as well. The skin has turned red in color as well. So in such cases, what is the name of this type of psoriasis? Massive scaling. See the image? Too much of scaling over the body, right? So here, what do you call it as? Very good. Psoriatic erythroderma. So when it comes to psoriatic erythroderma, how much percentage of the body surface area should turn red in color? How much percentage of the body surface area should turn red in color? Yes, when more than 90% of the body surface area turns red. This is called as psoriatic erythroderma. Very good. It is considered to be a dermatological emergency, right? So we will also quickly learn what are the nail changes in psoriasis. So if you remember the nail changes in psoriasis, we can study it as POISON. That is poison, right? So what is poison? If all of you knows. So Soya Wani is saying that P is for pitting of the nails. Excellent. So that is pitting of the nails. What is OI together? So OI, as you can see in this image, the second one. So this is going to be oil drop sign. Very good. Oil drop sign. How about S? S means this one. I'll just zoom this for you. You can see that there is a thickening of the nails just beneath it, right? So what is that called? Very good, Sagufta. It is called as subungual hyperkeratosis. And what about O? O means there is a separation of the nail from the nail bed, especially in the distal part. What is that called? Sagufta, Shaikh, Rishabh, Mondal, Soyas, all of you are right. So this one is called as onycholysis. Onycholysis. Amazing. And what is the last one? N. N is where the entire morphology of the nail is lost. So yeah, it is going to be irregular pitting in cases of psoriasis. Okay? Yes, this is called as nail plate dystrophy. It's called, this is the last one is nail plate dystrophy. So please remember, all these are the various nail changes in psoriasis. So Ambali is giving the entire write out now. Very good, Ambali. So now let's see another one. Now see this image and tell me what is the name of the sign that can be seen in psoriasis. And this is the image for you. So what is the name of this sign? And you have few seconds to answer. So the name of the sign is Auspitz sign, isn't it? Auspitz sign. Because what we do whenever we scrape the lesions in a psoriatic patient, the pinpointed bleeding spots. So Sagufta, Mondal, Harsh, all of you are answering it right. So this is pinpointed bleeding spots. Pinpointed bleeding spots on scraping the lesion. On scraping the lesion, that is called as Auspitz sign. So another bonus question for you. What about this one? What about this? So here what I can see is that there is a linear lesion over the skin. I'll just zoom this for you. So this is probably after scratching over the skin, the patient has developed some new lesions over the skin. What is this? Is this called? Yeah, this is called as the Koebner phenomenon. So appearance of new skin lesions at the site of trauma. It's called as a Koebner phenomenon. And for Koebner also, during our lectures, we try to remember three diseases that usually shows Koebner. And very good, Dr. Shaikh. You're saying that Musaddiq is also saying that this is also called as isomorphic phenomenon. It is very good to remember all these names because you have no idea how the exam questions may be asked, right? So what are the three diseases where you find Koebner? LVP kya hai? What is L? L stands for lichen planus. L stands for lichen planus. How about V? V stands for very good vitiligo, vitiligo, and P stands for psoriasis. So these are the diseases which shows Koebner phenomenon, a very important phenomenon, has been a previous year MCQ as well. Yeah. So now let's see what happens in Pityriasis rosea. So in Pityriasis rosea, I want all of you to remember what is the name of the first lesion. Now, who remembers the name of the first lesion? So when I see this image itself, I am easily able to find out what is the first lesion. I'll just zoom this. This is going to be the first lesion that the patient developed. So why am I so confident to say that this is the first lesion? Kyunki this is the largest lesion, and this lesion is also called as the herald patch or mother patch. So this is called as the herald patch or the mother patch, isn't it? And in case of pityriasis rosea, tell me, are you going to treat this patient with steroids or antihistamines or antibiotics? Or how are you going to treat this patient of pityriasis rosea? Would you like to use some steroid? Would you like to use some antihistamines? Or would you like to use some antibiotics? What is it? So why is Pooja saying no? Why is everybody saying yeah? This is self-limiting. So this is a self-limiting condition. And in this disease, you also find some typical scaling as well. The scaling in this disease is going to be collarette of scales or a cigarette paper kind of a scaling can be seen. So now let's see one more image. So in the next image that you can see here, I'll just zoom this image for you. Imagine that there is no question asked. It is just an image. Identify. Are you able? It's stuck again. Just a minute. Can you please confirm if I'm audible and visible now? Because many of you said that my entire internet has gone. Now is it fine? Okay, now it's fine. Sir, okay, thank you for confirming. So now let's see, this is violet in color or violaceous in color. That is why we said this is lichen planus. And how about the scaling in lichen planus? The scaling, does it have a peculiar name or not? So what is the name of the scaling? Yes, the name of the scaling would be 𝐒𝐿𝐻𝐿𝐿. The name of the scaling is Wickham's stride. And in lichen planus, what is the importance or significance of this lichen planus when it comes to the involvement of the oral mucosa? Like in oral lichen planus, what is the significance? Why is that the physician is very concerned whenever you see that there is a patient who is having lichen planus, especially in the oral mucosa? The reason is that this is a pre-malignant condition. And what is it pre-malignant to? It is going to be pre-malignant to squamous cell carcinoma. It is going to be pre-malignant to squamous cell carcinoma. Today, while we started our session, we discussed about some alopecia that is associated with lichen planus. So, alopecia associated with lichen planus, is it going to be a cicatricial alopecia or a non-cicatricial alopecia? So in cases of lichen planus, it is going to be, yes, cicatricial alopecia, which means the patient will end up in having a scarring alopecia, right? The patient will end up having a scarring alopecia. Okay. So now let's go to the next one. Some of the nail changes that you can see when it comes to lichen planus. So what are the nail changes that you can see in lichen planus? So what about this kind of an extension, a wing-shaped extension from the nails? Very good. So this is called as pterygium of the nails. And in cases of lichen planus, again, you can see that there is a nail plate dystrophy as well, right? But what is the most common nail change? What is the most common nail change that is associated with lichen planus? Anyone? Yeah, all of you are right when it comes to pterygium. So pterygium is completely correct, dorsal pterygium. Yes, very good. So the most common nail change is going to be thinning of the nails. Excellent. I'm getting all the answers, isn't it? So the most common would be thinning of the nails. Now moving to another very important topic that is called as urticaria. Now what happens in urticaria is the patient will develop some kind of a itchy skin lesion, right? So when it comes to urticaria, can you tell me what is the name of the skin lesion that you can see in urticaria? Anyone? Yes, the skin lesions that you can find in urticaria. Urticaria is always going to be itchy, and the name of the skin lesion is called as wheals or hives. It is going to be wheals or hives. And by definition, within how much time is an urticaria going to disappear on its own? Like without any treatment, it may disappear. So by definition, it disappears within 24 hours, right? So it is going to disappear within 24 hours. That is going to be the exact definition of urticaria. So please remember, the drug of choice in all the types of urticaria, is it going to be a steroid? Is it going to be any immunosuppressants? Or is it going to be antihistamines? What should be the drug of choice when it comes to urticaria? The drug of choice is going to be antihistamines. It is going to be antihistamines. Very good. So when it comes to urticaria, there is something which is called as dermographism, which is very important. So right now we will try to recollect three types of dermographism. The first type of dermographism that we will learn is red dermographism. So in red dermographism, that is seen in chronic urticaria. What about white dermographism? White dermographism. Can you just try to recollect key Where did we learn about white dermographism? White. Excellent. White dermographism is seen in atopic dermatitis. Atopic dermatitis. How about black dermographism? Anyone? Black dermographism? I did not get the answer for black dermographism yet. Yeah, very good. Pooja, Sagufta, both of you are answering. This is seen in nickel dermatitis. This is seen in nickel dermatitis. Okay? So please keep this thing also in your mind regarding dermographism. So now when we go to this next page, what I can see is, yeah, very good. Soim and Harsh Mondal is also answering. Rishabh, excellent. All of you, good. Now just see this image. I'll just zoom this image for you. What I can see or what I can predict is somebody has stroked the skin like this. After stroking the skin, the patient has developed a erythematous lesion around this stroking over the skin. And I can see that there are lot of hyperpigmented macules over the skin. So does all these things ring a bell? What is the diagnosis or what is the clinical sign? Yes, this is called as Urticaria pigmentosa. And this stroking over the skin, what is the name of this sign? Yeah, Rishabh, it is cutaneous mastocytosis. I agree. Can you tell me the name of the sign? Dr. Shaikh is answering it. Sagupta is answering it. This is called as diarrhea sign. This is called as diarrhea sign. So as all of you have told me, this is an example of cutaneous mastocytosis. It's an example of cutaneous mastocytosis. Now, when you see this next image, can you tell me a single diagnosis? Probably this is a child who has come to you with swollen lips. अब ये क्या है? What is this swollen lips all about? Very good. This is called as angioedema. So the spot diagnosis here should be of angioedema, because many times what happens, a patient can have urticaria. Along with urticaria, the patient may also develop a swelling of the lips, swelling of the eyelids and all. So whenever there is an edema that goes beyond the dermis, that is up to the subcutaneous tissue, we call it as angioedema. Let us also learn different types of erythemas. Okay, it's not learning, let us revise now. Okay, now seeing the first one, we'll just label these images one by one. The first one, when you see this, does any single erythema come to your mind? For me, there is something in the center and there is an erythema like this. What is it? Very good. So I'll just give few more seconds for others also to answer. So this one is called as erythema multiforme. So this erythema multiforme, it can be seen due to a lot of causes. It can be caused due to drugs or it can be caused due to infections. Which infections? Infections can be herpes simplex virus or it can be mycoplasma. Now, let's see the second one. Okay, this erythema. So in this second erythema, what do you see? Again, I can see something very similar to erythema multiforme. Because central mein there is something like this red and there is another rim of erythema. The only difference is the size is very big now. अब ये क्या है? कौन सा erythema है? What is this? Yeah, it looks like a target, Zoya. So this is target-like lesion. I would say this is target-like lesion. That is your clue. And what is this? Yeah, Dapper Lama says Lyme's disease This is going to be erythema chronicum migrans. Very good. So this is erythema chronicum migrans, which is seen in Lyme's disease. This is seen in Lyme's disease. Very good. Now let's see one more. Now this is a patient who is having some heart disease and has developed an erythema which is transient in nature. क्योंकि यहाँ पे तो erythema है, so in this region the erythema has now already disappeared. Now what is this? The clue for you is the patient is having some heart disease. Very good. So this is called as erythema rheumaticum, erythema marginatum, right? Erythema marginatum rheumaticum, because it is seen in rheumatic heart disease. What if the patient is developing this kind of an erythema? So you can see that it's a very beautiful pattern that you can see over the skin, but this pattern is resembling a cross section of a wooden plank. Isn't it a wood grain appearance? But this is not a good news as well. What is the name of this erythema? Very good. Erythema gyratum repens. It is called erythema gyratum repens, because this can be a marker of malignancy like lung cancer, breast cancer and all. And the last erythema that we have here, where it is a child who is having a red color face, probably with fever as well. So if there is a fever as well and it looks like a slapped cheek appearance, what is the name of this kind of an erythema? Yes, slapped cheek appearance, I agree with Soya. But what is that? Erythema infectiosum. So this is called as erythema infectiosum, because this patient has a slapped cheek appearance. The patient has a slapped cheek appearance. It can be seen in fifth disease, right? It can be seen in fifth disease. So just moving further now. So here, I'll just see this one. You can see that there is a patient who is showing you some depigmented lesions over both sides of the upper limb. What is this? Very good. So this one should be vitiligo. And which type of vitiligo can it be? Because the patient is showing you like this. Since you can find symmetrical lesions, this should be vitiligo vulgaris, right? It should be vitiligo vulgaris. What if you get an image like this for your exam, where there is a depigmented lesion, but I can clearly draw a line like this in the midline because the vitiligo lesions are not crossing the midline. अब ये क्या है? This is very good segmental vitiligo. So this one should be a segmental vitiligo. Now please remember, all these cases of vitiligo, this is a autoimmune disease. So this is going to be a autoimmune disease. Okay, vitiligo is a autoimmune disease. Yes, Mondal, there are different types of vitiligo, जैसे acrofacial vitiligo हो गया, या फिर focal vitiligo, या फिर vitiligo universalis. All these are different types of vitiligo. So here I just wanted to show you the spot diagnosis just to test if you are able to answer what type of vitiligo is it. So most of you are able to do it. Now if you see an image like this for your exam, this was asked in the last FMG exam as well. You get a face of the patient and what I can see is a brown colored patch. Brown colored patch over the face of a patient. What is this spot diagnosis? Pooja says melasma. Does everybody agree to her? Soya, Sagufta, all of you, Harsh, everyone is now saying the same thing. So I also agree to all of you that this is called as melasma, because in melasma you get a brown patch over the face. You get a brown patch over the face. Now, what about in pregnancy? In pregnancy, if a patient gets melasma, does it have any peculiar name? Yeah, Soya says that this is called as cloasma, or the mask of pregnancy, or the mask of pregnancy. Now, what is the drug of choice in melasma? So what is a drug that you can use for the treatment of melasma? Yeah, Harsh and Rishabh is also completely right. अभी ये बोलो कि what is the drug of choice? The drug of choice is going to be hydroquinone. It is going to be a skin lightening agent, right? Skin lightening agent. Now, if I zoom this next image for you, can you tell me how is melasma different from this? How is melasma different from this image? अभी मुझे यहाँ पे क्या दिख रहा है कि there are a lot of small brownish hyperpigmented, yeah, these are called as affiliates or freckles. Very good. Macules दिख रहा है इधर, है ना? So this is called as freckles or affiliates. So यहाँ पे the most important finding is you get brown macules, क्योंकि in melasma we saw there are brownish patches over the face, whereas if you find brownish macules, that is called as freckles or affiliates. Very good. Now let's see the next one. In the next one, you can see that this is not brown anymore. This is dark brown, या फिर black color, isn't it? So when you see this black colored macules over the face as well as over the oral mucosa, what is this? Dr. Pratiksha says it is Peutz-Jeghers. This is going to be Peutz-Jeghers syndrome. I completely agree. Abhi ye skin lesion, what is it called? This is called as lentigenes. This is called as lentigenes. It is seen in Peutz-Jeghers syndrome. So this can be seen in Peutz-Jeghers syndrome. Very good. Now these are examples of 𝐒𝐄𝐈𝐀 macules. Okay, 𝐒𝐄𝐈𝐀 macules, that is calm. Now my question is, where do you find these kind of 𝐒𝐄𝐈𝐀 macules? ये जो पहले का जो 𝐒𝐄𝐈𝐀 macules है, where do you find them? Brown color patches over the trunk. Think again, is it McCune-Albright? McCune-Albright is this one. Okay, this is seen in McCune-Albright syndrome. But the regular type of 𝐒𝐄𝐈𝐀 macules, this is seen in neurofibromatosis, especially in NF1. It is seen in NF1. So whoever is answering it as NF2, remember NF2, you can see both freckles, okay, that is axillary freckling, but it is more commonly seen in NF1 and not NF2. Yes, Chetan, I'm sure we are having leprosy as well. Okay, it's coming up in some time. So now let's see another one. So let's do all these spotters now. Okay, we'll see one by one images, and then we'll do the spotters now, and then we will talk about leprosy in some time. Now let's see. This is all blue color discoloration over the skin. Let's quickly label it what I want. What is this type of ceruloderma called? Ceruloderma matlab blue colored skin. अभी ये क्या है? Pratiksha is saying this is Mongolian. I also agree with her. This is called as Mongolian spots. This is called as Mongolian spots. Now, what is the next one? Next one, यहाँ पे जो दिख रहा है, that is over the face as well as over the eyes. If you find this bluish discoloration, is it nevus of aorta? Yeah, nevus of 𝐼𝐻𝐿. What do you think? Is it nevus of aorta? Yeah, 𝐼𝐻𝐿. Yeah, this is nevus of aorta. So try to remember like this: aorta, nevus of aorta, where including the hair is, including the eyes is involved. This is called as nevus of aorta. Then what is this? Like a child who is having a bluish discoloration over the shoulder area. This is nevus of 𝐼𝐻𝐿. This is nevus of 𝐼𝐻𝐿. So very good. So in all these cases, what you can see is a bluish discoloration over the skin. Now coming to another very important topic, and this very important topic is called pemphigus vulgaris. Now for your exam, pemphigus vulgaris, remember, you have to see what is a clinical scenario in pemphigus vulgaris. Pemphigus vulgaris means the patient will always come to you with oral mucosal erosions along with a flaccid bulla in the trunk. So what all of you will remember when you go for your exam is, where does the symptoms of pemphigus vulgaris starts from? Oral mucosa. So if you find oral mucosal erosions followed by flaccid bulla over the trunk, that is called as pemphigus vulgaris. क्योंकि यहाँ पे defect क्या है? Defect is in a desmosome. Which desmosome? This is desmoglein 3 more than desmoglein 1 here, isn't it? Yes. And I'm getting so many other findings of pemphigus vulgaris in the chat box. Let's learn those findings in with the images also. These are oral erosions in pemphigus vulgaris. So in pemphigus vulgaris, let's learn about all these findings. Now see these images now and tell me one by one what are these findings. Why did I give you an image of a graveyard when it comes to pemphigus vulgaris? Why image of a graveyard in pemphigus vulgaris? Yes, because here you have a suprabasal split, and because of the suprabasal split, there is a row of tombstone appearance of the basal keratinocytes. Very good. So who has answered it? Pratiksha, Musaddiq, Harsh, Zoya, Mahesh, Sagufta, all of you have answered it. Excellent. So that is the right answer here. Now tell me, what is this investigation? और ये investigation का finding भी क्या है? I've zoomed this image for you. So what investigation is this and what is this investigation finding? Yes, this is called as direct immunofluorescence, where you can get a fishnet pattern or a chicken wire pattern. So you can see a fishnet or a chicken wire pattern in the direct immunofluorescence in pemphigus vulgaris. Now in pemphigus vulgaris, there can be some of the clinical signs as well. So what are the clinical signs that you can elicit in pemphigus vulgaris? Because imagine that I'm applying a tangential pressure like this over the skin, and the skin may get peeled off. What is the name of this sign? So this sign is called as Nicholsky sign, isn't it? And what are the diseases that comes to your mind when I say Nicholsky sign? Nicholsky sign can be seen in which all diseases? You can see in pemphigus vulgaris, I agree. You can see in pemphigus foliaceus. Any other disease where you can find a Nicholsky sign? Very good, Dr. Rishabh. It can be seen in staphylococcal scalded skin syndrome as well. So Mishra Arpit is saying about Asbo-Hansen sign. अभी कौन सा है Asbo-Hansen sign? If there is a bulla like this, if you try to apply a pressure laterally or above this bulla, if the bulla is going to move, this is called as Asbo-Hansen sign or a bulla spread sign. Asbo-Hansen sign or a bulla spread sign. So a few things about pemphigus foliaceus. Because what is more important is on the day of the exam, what is the clinical differentiating factor for pemphigus foliaceus from pemphigus vulgaris? What is the answer? So in pemphigus foliaceus, what is not present? There is no oral mucosal involvement. Okay, there is no oral mucosal involvement. If the patient is complaining of flaccid bulla without any oral mucosal involvement, that is going to be pemphigus foliaceus. And here the defect is going to be desmoglein 1 defect. Desmoglein 1 defect. Usually it is seen over the seborrheic sides as well. Remember the upper part of the trunk, that is called as the seborrheic sides. Now what happens in bullous pemphigoid? अभी हमने डिस्कस किया pemphigus vulgaris, फिर डिस्कस किया pemphigus foliaceus. But pemphigus vulgaris and foliaceus both was having a easily breakable bulla, that is a flaccid bulla. But bullous pemphigoid mein, what is the type of bulla that you can see? You can see a tense bulla in a elderly patient. So whenever you can see a very tense bulla in an elderly patient, so this is called as bullous pemphigoid, isn't it? And here what you have to see here is, in this case, what is the name of this direct immunofluorescence finding? What is the name of this direct immunofluorescence finding when it comes to bullous pemphigoid? Because in bullous pemphigoid, you can see that the patient will have not a chicken wire pattern or a fishnet pattern. Here you can see a linear fluorescence in the basement membrane zone or dermoepidermal junction. Okay, linear fluorescence can be seen in the basement membrane zone or dermoepidermal junction. So as many of you have written in the chat box, the defect here is going to be BPAG2 more than BPAG1. The defect is going to be BPAG2 more than BPAG1. Clear? So now let's see some of the skin malignancies as well. So when it comes to skin malignancies, the first one we are talking about is a basal cell carcinoma. Yeah, the last exam mein, they asked you about basal cell carcinoma, isn't it? So in basal cell carcinoma, here what you can see is, this is a very typical lesion. Okay, you see anything because the most common site of a basal cell carcinoma is going to be the face. And you have to make a spot diagnosis because this image will help you in the spot diagnosis. Because you can see a rolled up borders with central telangiectasia can be seen. So what is central telangiectasia mean? When I zoom this image, some red color that you can see in the center, so those are all telangiectasia, and you can see some rolled up border, isn't it? And the most common site is going to be the face. So whenever you see some lesions like this over the face, that is going to be squamous basal cell carcinoma. And the histopathological examination, What do you find in histopathology? The histopathology, you can see there is peripheral palisading of the basal cells. You can see that there is a peripheral palisading of the basal cells. Okay, that is how you can diagnose. What about malignant melanoma? Whenever you see that a patient has developed a new mole, you always will have to evaluate it with ABCDE algorithm, right? So what is ABCDE? So Doc Saab is saying ABCDE, where A stands for asymmetry. So the lesions may be asymmetrical, the border would be irregular, there may be a color variation, the diameter would be more than 0.6, sorry, the diameter should be more than 6 mm, and E stands for evolving in color, size and shape, right? So whenever you see an image like this, here there is a lighter color, here there is a darker color. If there is a lesion that is more than 6 mm, in all those cases, we can suspect malignant melanoma. Malignant melanoma. So moving to another part. So what are these? There is a patient who is coming to you who says that there is a hyperpigmentation over the axilla, and when we turn on a Wood's lamp over the lesion, you can see that that area of the skin has turned red in color. Not hidradenitis suppurativa. This is going to be erythrasma. Okay, in erythrasma, you get coral red fluorescence. Wood's lamp examination. And what is the causative in erythrasma? Is it caused by streptococcus, staphylococcus, pseudomonas, or anything else? What is it? Yes, it is caused due to Corynebacterium. So Corynebacterium can be the causative organism when it comes to erythrasma. Okay, it is not malassezia. Please remember, it is a condition caused by a commensal bacteria, which is called as Corynebacterium. So let's also do few things about another common bacterial infections like furuncle and carbuncle. So let's see this one as well. So how can we label everything? What is the first one? When you see multiple pustules together, this is called as folliculitis. Whereas when you see a pus forming infection, isn't it? So when you see a pus forming infection of a single hair follicle, this is called as furuncle. See, all of you must have seen a boil, isn't it? A simple boil. I'll just zoom this for you. So when you see that in this image, there is a pus underneath the skin. And which is a hair follicle that is infected? There is a hair follicle that is infected here. So what you will do here is you can do an incision and drainage and then start the patient on antibiotics. This is called as a furuncle. And how does a furuncle differ from a carbuncle? Because in a carbuncle, this is a pus forming infection of multiple hair follicles. So when multiple hair follicles are infected, this is called as a carbuncle. Okay. And all these can come as a spot diagnosis for your exam, because in one of the FMG exam, they gave you an image of the nape of the neck, and that was an image of a carbuncle. Okay, when multiple furuncles are present, that is called as a carbuncle. And you already must have learned about impetigo in microbiology as well. We have learned this in dermatology as well. So how many types of impetigo is present? There are two types of impetigo. One is non-bullous and the other one is bullous impetigo. So in the cases of impetigo, what is a differentiating feature when it comes to impetigo? So in impetigo, let's say the first image, non-bullous impetigo, how are you able to say that कि ये impetigo है? Yes, because of the honey colored crust, right? And what is the color of the crust when it comes to a bullous impetigo? So this bullous impetigo, what is the color of the crust? The color of the crust is going to be varnish crust. So that's going to be a varnish crust. So brown color or a varnish crust, think about bullous impetigo, whereas golden yellow honey colored crust, that is going to be a non-bullous impetigo. There are two more bacterial infections. Let's say one is most common in the face and another one is most common in the lower leg. What are these infections called as? Anyone in the chat box? What is this? Over the face, reddish erythema, all those things can be seen. Very good. So who answered it? Pooja. Excellent. This is called as erysipelas. And the second one, which is very common in the lower leg, this is called as cellulitis. This is called as cellulitis. How to differentiate between bullous impetigo and pemphigus? See, in pemphigus, always oral mucosal involvement followed by skin lesions. Whereas impetigo is a bacterial infection. It can be localized to a certain area and there will be no oral mucosal involvement as well. Okay, so yeah. Okay. Now this one is going to be cellulitis. In all these cases, the patient may present to you with fever along with chills. Okay, fever along with chills. So please remember erysipelas as well as cellulitis. The patient may present to you with fever and chills. Now seeing these, what comes to your mind? Is it a bacterial infection or fungal infection? Let's talk about the first image now, where a patient is having a hair loss in the scalp and there is a swelling in the scalp. So this one is called as Kirion, isn't it? So Pooja, Mishra, Musaddiq, all of you are answering it as Kirion. क्योंकि यहाँ पे we find a tender boggy swelling of the scalp. And what about this one? What is the spot diagnosis when you see the next one? Yeah, it is a round lesion. Matlab, ringworm comes to our mind, right? Ringworm. So what is the medical terminology for a ringworm? That is called as tinea corporis. It's called as tinea corporis. So in all these cases, what is our investigation of choice? Our investigation of choice in all these cases should be, anyone? 𝐂𝐄𝐄 test, isn't it? So we can simply do a skin scraping. So once you do a skin scraping, if you are able to see a fungal hyphae, then you can start the patient on antifungal agents, right? Now, if this is meant to be a fungal infection, what is the name of this fungal infection? What is this fungal infection? So what is this tinea? Is it tinea versicolor? Is it tinea manum? Is it tinea pedis? Or is it tinea? Javier says Dobie itch. Yes. So this is called as tinea cruris, also called as the 𝐒𝐂𝐈𝐀H or a 𝐒𝐿𝐻. Okay, all these are the same. Tinea versicolor, I'll show you the image. It is not tinea versicolor right now. This is going to be the groin area. Isilye we call it as a tinea cruris or 𝐒𝐂𝐈𝐻. So in one of the FMG exams, they asked you about what is tinea incognito. What is tinea incognito? This is going to be steroid modified tinea, isn't it? It is going to be steroid modified tinea. So what happens here is, whenever in fungal infection, we are supposed to treat a fungal infection using antifungal agents. Instead of antifungal agents, if you use a steroid cream to treat a fungal infection, that is called as tinea incognito. तो यहाँ पे treatment क्या होना चाहिए? You have to stop steroids and start antifungals. You have to start antifungals. So earlier somebody was asking about tinea versicolor. Now what is tinea versicolor or pityriasis versicolor? It is going to be, see this term versicolor, right? So the patient can either present to you like this, that is hyperpigmentation, or the patient can present to you like this, that is hypopigmentation. So when a patient presents to you with either a hyperpigmentation or a hyperpigmentation over the trunk along with rice powder like briny scaling, that is when we diagnose pityriasis versicolor. And as I told you earlier, the 𝐂𝐄𝐝 image we had discussed it already today. That is going to be a banana and grapes or a spaghetti and meatball appearance. And in this case, patients, this is mostly caused due to Malassezia globosa and Malassezia perfor. And you can treat the patient with some antifungal agents like ketoconazole. Isn't it? Very. Now, few words or a quick revision of some deep fungal infections. अभी deep fungal infections में क्या हो रहा है? The first image. Can anybody tell me कि what is this first image? क्योंकि if I just zoom this image, what I can see is there are some nodular lesions like this, and these nodular lesions, they are arranged linearly. That is a clue for you. And what is this condition? Very good. So this is called as porotrichosis or the rose gardener's disease. So in sporotrichosis or in rose gardener's disease, you can see that there are multiple nodules which is arranged linearly because this is arranged linearly as it runs along lymphatics. It runs along a lymphatics. Now what about the next one? If the next image comes to you for your exam as a spotter, is there any fungal infection that comes to your mind? Yes, it should be mycetoma, isn't it? So even though mycetoma is not a purely fungal infection, it can be either bacterial or fungal, but more common is going to be fungus. It is also called as the Madura foot, right? It is also called as the Madura foot. So in most of the FMG exams, what happens is the question comes that a farmer comes with a big swollen ankle and they'll give an image like this. In those cases, the most likely diagnosis should be a Madura foot or a mycetoma. Now here, just two things to ask you. What is the spot diagnosis and what is the histopathological finding? Because this does not require any big explanation. It is called as, what is this? Yes, this is called as molluscum contagiosum. This is called as molluscum contagiosum. And what is the histopathological finding? Histopathological finding? Yes, it is called as HP bodies. So what is HP bodies? Henderson-Patterson bodies. Henderson-Patterson bodies. Dr. Rishabh, chromoblastomycosis or mycetoma, confusing in the image. It's a good confusion that you have here, because this one is not very typical of that mycetoma image. Okay? Chromoblastomycosis can also have a cauliflower like lesion. This also can be chromoblastomycosis as well, based on the clinical presentation of the patient. It's a very good differential diagnosis. Okay, so this is about molluscum contagiosum. Now this is another topic which has been asked multiple times for your exam. It's a very repeat question. Now whenever you find warty lesions in the genitalia of the patient, what is the diagnosis? Warty lesions in the genitalia is called as condyloma acuminata, isn't it? It is called as condyloma acuminata. And what is a type of human papilloma virus which can cause condyloma acuminata? Yeah, this is called by HPV, human papilloma virus. You're absolutely right. So this is mostly due to HPV 6 and 11. So 6 and 11, is it going to be a high grade or a low grade? So remember, everything that is seen in the skin is going to be a low grade, isn't it? It is going to be low grade. And when it comes to condyloma acuminata, what is our treatment of choice? Do you remember what is the treatment of choice when it comes to condyloma acuminata? Anyone? There are two names that I would like to listen from you when it comes to the treatment. Okay, one is podophyllins, isn't it? The other one is imiquimod. Podophyllins and imiquimod, these are used in the treatment of condyloma acuminata. Now jumping to some of the genital ulcers. Now what is this ulcer? Two images are given to you. One is a very clean looking ulcer, and the next one is a investigation where you can appreciate the motility of the organism. Yes, so this is going to be syphilis, because you can see that there is a clean indurated. In syphilis, is it painful or painless? It's a painless ulcer, correct? Painless ulcer can be seen. And what is this investigation? So yeah, Soya is saying, Javier is also saying, this is called as a dark field microscopy. And what is the motility of the organism here? The motility of the organism is compared to Dr. MSH has answered it already. So this is going to be corkscrew motility. So this is going to be corkscrew motility. And how about this one? If you get a patient is having a painful ulcer along with buboes, and you can see that this is the finding in a gram staining, some very peculiar arrangement in a gram staining, and this gram staining can be compared to a school of fish appearance. So what is the answer? All of you, please let me know in the chat box ki answer kya hai. Painful ulcer with a painful bubo and school of fish appearance. Yes, very good. So here the correct answer should be chancroid. So here the correct answer should be chancroid. So Dr. Rishabh is adding that it is also called as railroad track appearance. Very good. Railroad track appearance can be seen. अब ये क्या है? If it is coming for your exam as a genital ulcer, and I can see that this is beefy red in color and it bleeds to touch. And it bleeds to touch. And you can see that when I zoom this image on a tissue smear, you find something like this. So what is this? A closed safety pin appearance. And that is called as Donovan bodies. So now all of you know what's the correct answer. So the correct answer here should be donovanosis. The correct answer here should be donovanosis. And let's also discuss about how does a patient present to you with herpes genitalis. So when it comes to herpes genitalis, the patient will present to you with multiple vesicles which will lead to multiple painful genital ulcers. So when the patient will present to you with multiple painful genital ulcers with painful lymphadenopathy, that is called as herpes genitalis. Please remember for your exam, this is the most common type of genital ulcers. It is the most common type of genital ulcer. Javier says HSV2 mainly. Correct. Now, this is something tricky, or I wish that all of you answer the correct answer for this image in the chat box. Because earlier we learned about warty lesions in the genitalia. Warty means rough surface lesions. But यहाँ पे it's not rough surfaced. You can see some flat topped lesions in the genitalia. Mahesh is answering it right. How many of you are getting it right? When you see flat topped lesions in the genitalia, this is called as condyloma lata. Condyloma lata. क्योंकि earlier we learned about condyloma acuminata. ये हो गया condyloma lata. This can be seen in secondary syphilis. This can be seen in secondary syphilis. And when it comes to genital ulcer disease, genital ulcer, I'm sure that that will also be discussed in gynecology. So we'll just talk few words about it and then move to the next one. So when it comes to genital discharge, it can be either a gonococcal discharge or a non-gonococcal. क्योंकि gonococcal urethritis, non-gonococcal urethritis. When do you say that this is gonococcal urethritis? When the patient will complain of severe dysuria, isn't it? Whereas in non-gonococcal, there would be a variable dysuria. So when the patient is having a severe dysuria, along with, what is the second most important finding? What happens in a gonococcal urethritis? Anyone? Along with dysuria, what is the kind of discharge that can be seen? You can see a mucopurulent discharge, isn't it? So you can see a mucopurulent discharge. That is how you can diagnose a gonococcal urethritis. Whereas how do you diagnose a non-gonococcal? When the patient says some variable dysuria along with a scanty discharge, that is when you can suspect a non-gonococcal. As the name says, gonococcal means you can think about Neisseria, gonorrhea, whereas non-gonococcal can be caused by various organisms, out of which the most common should be chlamydia. Isn't it? The most common should be chlamydia. And next one is about scabies. Now tell me, what is the typical lesions that you can see in scabies, especially in between the finger webs? Anyone? Can you answer me quickly? So in scabies, the type of lesions that you can find is very good. These are called as the furrows. And whenever there is a scabies which shows some nodules in the scrotum, these are called as nodular scabies. So in the last NEET PG exam, they asked you regarding the treatment of scabies. So how can you treat scabies? Anyone? Yes, scabies, the drug of choice is going to be permethrin. And how much percentage of permethrin can you use? You can use 5% of permethrin, right? In the cases of scabies. So now let's see the next one. What if you get a child who is complaining of some lesions over the elbow? And when you palpate these lesions over the elbow, you can see that there is some feeling like palpating a small frog or a toad. What is it? Yes, this is called as rhinoderma, which means a toad-like skin. And this can be seen in association with different types of nutritional deficiencies. But let's see some more nutritional deficiency. This is another topic which is repeated multiple times in the FMG exam. So what is this nutritional deficiency? Yes, it can be seen in different types of nutrition deficiency, Mahesh, like rhinoderma, vitamin A, vitamin B, vitamin C, all those things can be there. Now, this one is due to niacin deficiency or vitamin B3 deficiency. And what is the name of this disease? This disease is called as pellagra. Very good. So, this disease is called pellagra. And this image where you can see that there is a photosensitive rash around the neck region. So this photosensitive rash, what is it called as? Yes, this is called as the Kezzel's necklace. And there is one more rash which you can see, a shiny rash which you can see over the dorsum of the hands. Any idea what is the name of that thing? This is called as gauntlet sign, also seen in pellagra. It is called as gauntlet sign. And whoever is answering the 4Ds like diarrhea, dermatitis, dementia, death, that's all correct. Now see this image of a baby, and the baby is having some periorificial dermatitis like this around the nose, around the perianal region, around the mouth. So what is the diagnosis here? Yes, Rishabh, it will go away. The photosensitive rashes and all will go away once the nutrition deficiency is taken care. Yes, so this is acrodermatitis enteropathica. So this acrodermatitis enteropathica, which you can see in this image, so this is due to the deficiency of, Javier says FMG December 2024. Yes, another very repeated topic. So what is this due to? This is due to the deficiency of zinc, right? It is due to the deficiency of zinc. So what you should always be seeing in these images is a periorificial dermatitis. So you must be seeing a periorificial dermatitis. And few things about cutaneous drug eruptions. So what if a patient develops a hyperpigmented macule or a patch after taking a drug? And every time the patient takes the same drug, the lesion reappears at the same site. Based on this history, can anybody answer what is the type of Drug eruption? Yes. So this is called as a fixed drug eruption, where the most common site would be lips and genitalia. Okay, every time a patient takes a drug, he develops a hyperpigmentation. Yes, Prasadik, NSAIDs are going to be the most common category of drugs which causes fixed drug eruption. Now, talking about some a very severe type of drug eruption, and what is that? That is called as Stevens-Johnson syndrome and toxic epidermal necrolysis. So, what happens in Stevens-Johnson syndrome and toxic epidermal necrolysis? There is going to be a severe peeling of the skin along with the involvement of at least two mucosa, isn't it? There would be an involvement of at least two mucosa. That is where you can find Stevens-Johnson or toxic epidermal necrolysis. Can anybody tell me what is the basic difference in terms of body surface area involved? Matlab, in Stevens-Johnson syndrome, how much percentage of body surface area is involved? And in toxic epidermal necrolysis, how much percentage is involved? Very good, Dr. Shaikh. Less than 10% body surface area is Stevens-Johnson, and more than 30% body surface area is toxic epidermal necrolysis. Matlab, what is more severe? Toxic epidermal necrolysis is going to be more severe. And patient will be coming to you with a something like this. For yahan pe, earlier when we spoke about pemphigus, we spoke about 𝐒𝐿𝐄𝐝 sign. Here we call it as pseudo 𝐒𝐿𝐄𝐝 sign. Why? Because clinically the sign is the same. So clinically it is going to be the same sign, just like what we saw in pemphigus vulgaris and pemphigus foliaceus and all. But here what is different is the etiology is different from acantholysis. The etiology is different from acantholysis. Okay? Pseudo 𝐒𝐿𝐄𝐝. Pseudo 𝐒𝐿𝐄𝐝, I would say 𝐒𝐿𝐄𝐝 is seen in Staphylococcus scaled skin syndrome or Ritter's disease. Okay? So Dr. Depaki, please note it Staphylococcus scaled skin syndrome as 𝐒𝐿𝐄𝐝 and Stevens-Johnson syndrome as pseudo 𝐒𝐿𝐄𝐝. Okay, please don't make this mistake on the day of exam. So that is one small correction that I would like to highlight. And what about this image? In this image, you can see that the neck of the patient has become more thicker, velvety, hyperpigmented. So there is a velvety, hyperpigmentation over the neck, or sometimes it can be seen over the axilla as well. Can anybody tell me what is the spot diagnosis? Very good. The spot diagnosis is acanthosis nigricans. So the spot diagnosis is acanthosis nigricans. And remember, the most common cause would be obesity. And along with obesity, just like what you are writing in the chat box now, insulin resistance, metabolic syndromes, rarely some malignancies, all those things can be causes, but the most common should be obesity. Okay? So that is it. All about this discussion about FMG marathon of dermatology. And yes, I hope that all of you had a nice time revising the entire dermatology. I would agree that we were not able to go through all the topics, but whatever is the most important topics that we cannot omit, that all is being covered in this types. So leprosy, yes, why not? I can take a few minutes just to add few things about leprosy. I'll just add a page here. So all of you just focus here. So when it comes to leprosy, we always divide leprosy into various types. So just in few minutes we'll wind up. Okay. And in leprosy, when we talk about tuberculoid type of leprosy, remember every type of leprosy, the question will be a hypopigmented or erythematous patch with a sensory deficit. That is going to be the most common clinical scenario, isn't it? Hypopigmentation hoga or sensory deficit bhi hoga. And here, when we talk about TT type of leprosy, always remember the patient will present to you with a hypopigmented patch with a saucer right way up appearance. So all of you know the cup and saucer, the saucer right way up appearance can be seen. Whereas in borderline tuberculoid type of leprosy, you can see satellite lesions and pseudopodia. Satellite lesions and pseudopodia, which means outside the main lesion, if you can see some small lesions like this, those are called as the satellite lesions or pseudopodia. Pseudopodia means there will be some projections like this from the main lesion, finger-like projections, that is called as pseudopodia. After borderline tuberculoid, we have a borderline. MCQ will say that there is a hypopigmented patch along with sensory deficit, and this hypopigmented patch has a appearance similar to a inverted saucer appearance or a Swiss cheese appearance or a Swiss cheese appearance. Okay? Borderline lepromatous is less likely because it is non-specific. So the lesions, they start becoming symmetrical. So almost symmetrical lesions can be seen. But lepromatous leprosy is the one that has been asked maximum number of times. Okay. So what happens in lepromatous leprosy is you find nodular lesions over the face along with hypopigmentation over the trunk and lot many other features. Like, can anybody tell me in the chat box ki what do you see over the face or what is it compared to when it comes to leprosy? These are compared to leonine facies, a lion-like face or saddle nose deformity. And remember, in lepromatous leprosy, we have the maximum bacterial load and the patient immunity is the worst. So the cell mediated immunity is very low when it comes to a patient of lepromatous type of leprosy. Dapper Lama, very good. Glove and stocking deformity can also be seen. Glove and stocking deformity. There would be a diffuse sensory loss when it comes to lepromatous type of leprosy. So these are the common presentations in leprosy, and for your exams, please make sure that you go through the treatment part of leprosy as well, because in NLEP guidelines and all, some changes has come, because more rather than 2 drugs, we are now using 3 drugs when it comes to leprosy treatment as well. So that's all about dermatology marathon in PW MedEd, and I'm sure that Dr. Oshika ma'am's session is also going on of life of obstetrics and gynecology. I wish all of you the very best. Okay. And yes, these notes will be available in the Telegram group for FMG Sankalp in Telegram. Okay. For PW MedEd. And I wish you all the very best for your exams. So please come back with best results, and we are just waiting to celebrate your results very soon. Okay. The PDF in Sangalp FMG Sangalp Telegram channel. You can just scan this QR code and you can join the Telegram group. And in this Telegram group, this PDF shall be shared as well. Yeah, I wish you all the very best. Thank you so much for being such a very good interactive crowd, and all my prayers for you to have amazing results in the upcoming FMG exam. Thank you so much.